I think about 100, 150, you feel much more comfortable. I wouldn't start the difficult lesion in terms of like scar lesion or seeker lesion before my first 50. Sometimes you look at how people do it looks easy, but when you do it, it's not that easy. So be very important to be selective of your case, particularly when you first start. The first 30, 50, be careful.
Hi, everybody, and welcome back to another episode of EndoCast. I'm your host, Leslie Bishop, and this is episode 18 with our physician guest, Saowanee Ngamruengphong from Johns Hopkins Hospital. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you.
Dr. Nam, welcome to EndoCast.
Thank you for having me, Leslie.
I'm super excited to learn from you, to learn about ESD. I know you've been speaking at DDW on this topic. And before we do that, though, I just wanted to hear about your journey in endoscopy. So maybe you could share why you went into medicine, why you went into endoscopy, even why you went into third space.
So when I was in the university, at that time, I actually didn't quite know what I want to do. But my parents told me that being a doctor is a good occupation. And I feel, I spent some time in the hospital, like volunteer, and I find that I like helping people. So I decided to go to medicine. Okay, graduate from medical school in Thailand. Then I came to the US, did my residency in Texas, and GI fellowship in Florida at Mayo Clinic, Florida. And
in Jacksonville, which is where I live, yeah.
Yes, and advanced fellowship at Hopkins. So during the advanced fellowship, at that time, I tried to think about what kind of subspecialty in advanced endoscopy that I want to focus on. Even though I perform all kinds of advanced endoscopic procedures, but in academia, you need to have the niche. You have to build that. So, and I found removing tumor, cancer for the patients, prevent them from needing surgery is really fulfilling to me. I feel good that they get better from what I can do to help them. So I decided to spend some time in Japan to learn more of this advanced resection, because at that time there's very limited experience with ESD during my training, and even people in the US, there are not many people doing it. So decided to spend some time at several hospitals in Japan, and I learned a bunch from visual recognition, detection, classification, and procedure itself. And I'm thankful for my mentors who support me to go there, and my mentor in Japan who teach us. And that's how I start. And once I learn, it's not enough to come back and do it. So I did not do procedure in the patient over there, but learn from how they think, how they approach patient, practice in the animal lab, and then come back. I have to continue doing it here. Otherwise, you will forget that the skills, how to move things, how to move your body, how to move the scope. Long answer.
So no, go ahead.
Yeah. So but when we first start, we don't have that many patients. Although I know a lot of patients will be eligible, but I have to be selective of what kind of patients I'm gonna start my first ESD. I will not start in like 10 centimeter lesion in the colon. So we have to be strategic about it. Otherwise, we can cause a lot of problem. Where sometimes while I'm not having patients, I continue to practice in the lab to keep up my skills. At least I have to do at least 2 to 3 ESD in the pig stomach a month to keep up my skills.
This is after you went to training?
Yeah, I will come back when I don't have enough case to really do every week. I don't want to not doing for 2-3 months and then have another case.
Yeah.
It's not that we don't have patient, but I don't want to start at the difficult case. So it's just go slow.
So how long do you think it took before you felt proficient? Because one of the doctors I talked to said she went to 6 months of training. I think it was in Japan. I think it's where she went, where maybe 3 months she was observing and then 3 months she was working on patients. And 10 weeks seems quite short. So how long did it take you before you felt really proficient?
After 100 cases, I still continue to learn from every case I do, because when I finish, I could have done something different and maybe it's finished faster. But I think about 100, 150, you feel much more comfortable. I wouldn't start the difficult lesion in terms of like scar lesion or seeker lesion before my first 50. Sometimes you look at how people do it, looks easy, but when you do it, it's not that easy. So be very important to be selective of your case, particularly when you first start. The first 30, 50, be careful. Yep.
You can see why this is such a slow to adopt in the United States with that level of a learning curve and so few doctors in the United States to train anybody. I guess that's growing now.
Yes.
More and
there are
more
a lot
doctors.
more people doing it.
Yeah.
And in the past, you have to go to Japan. Now, it's much easier to find physicians to teach you to do the procedure. So I believe that it will become much more widespread use in the U.S.
So is this the main focus of your practice, is doing ESD?
So I would say not just they refer patients who have this condition. So then we work with the oncology team, a surgery team. What would be the best for them? Some patients come to see me because they need EUS staging. Some people come in and, they found this nodule. Then we have to work that out, what it is. Maybe some of these nodules, we don't even have to remove them. Then we don't do that. We do ultrasound, follow-up. Some of these need just EMR. So we kind of like GI oncology, what do you call it? Oncology GI. Sorry, I'm not sure how. That's a term that there's a GI cancer doctor that deal with a lot of cancer or patient with GI tumors. But then we decide whether they need ESD or maybe they need full thickness resection or they need something else.
All right, just stepping back, how do you define third space endoscopy?
Mm-hmm. Yeah, the other name of this is submucosal endoscopy, which you create space between mucosa and the muscle layer in order to perform the procedure you need. For example, if it's ESD, you create a tunnel underneath the mucosa and you want to remove the mucosa with the tumor. If the aim of the procedure is to perform myotomy, then that's POEM. So that's also the third space. Or if you want to create space to reach the tumor within the arise from the muscle layer to resect it, that's called STIR. So there are many variations of the third space, but basically it's a submucosal endoscopy.
And then what are the different indications for ESD throughout the GI tract?
The general indication is for lesions that has a low risk of lymph node or distant metastasis. Because when you remove the tumor from the GI wall, we don't address lymph node status. So it cannot be the advanced cancer. That's one. Two is it can be a benign precancerous or it can be superficial cancer. Three is a lot of patients that have prior procedure and then the tumor grow back and it's become very hard to remove the recurrent lesions. Then we can also perform ESD. This is in general that apply to all GI tracts.
And so where do you see the value of ESD compared to other tissue resection like EMR and other things?
Mm-hmm. I think it has its own place. Like for example, I told you about when I would consider ESD. Basically, because it takes longer and more difficult to do, not widely available. Therefore, we usually preserve for patients that we think gonna benefit the most. For example, the patient that has the high risk lesion, we suspect that might have superficial cancer. This would be the case that better if we can perform en bloc resection, which can be EMR if the lesion is small. But for larger lesion, then we need to perform ESD. So I think it's complementary. If it's cancer, usually we attempt ESD. If it's benign, like colon polyps, not that large, EMR usually adequate. For full thickness resection, it depends on like what indication to do full thickness resection. If it's for the, like for example, non-lifting lesion in the colon, which is common indication for FTRD. There are many options for those. You can do modified EMR technique. You can do ESD. You can do full thickness. It depends on several factors: patient anatomy, how long is the scar, locations. But some of these lesions can be managed by different techniques. Mm-hmm.
And then what is your thinking in terms of when you decide to do an EMR or when to decide to do an ESD or when they need to be sent out for surgery? Mm-hmm. What's your thought process on that?
Yeah, so if the lesion has appearance, endoscopic features, or even biopsy that show deep invasive cancer, like we can tell from how it looks that this is deep invasive cancer. Or if the lesion, you see mass in the colon and the CT scan show lymph node enlargement or liver masses, that probably metastasis, then we wouldn't be doing endoscopic resection. The lesion that we suspect that might have superficial invasive cancer, that's when we will do ESD, which sometimes is not that easy to predict. So the Japanese colleagues, they recommend that for lesion that you suspect intramucosal cancer, you should also attempt ESD, because we cannot be 100% by our eyes to estimate depth of tumor invasion. But for the benign lesion, like for example, serrated polyp that doesn't have any dysplastic change, EMR is usually okay because it's quick, safe, and very low risk procedure. Mm-hmm.
Now, I want to talk about getting referrals, because I know the doctor can send you a patient that's easier to perform ESD, or they can do some things that make it a little bit more challenging. So maybe you could talk on the positive side, what they can do when they're referring the patient to make it a more optimal case, and then maybe on the more negative side, like what things they might need to stop doing if they're doing too many tattoos or whatever.
I tell my fellows, okay, when you go out in your practice, before you start biopsy snare, spend a couple of seconds at least, look at the lesion and think about what it is. So basically, visual diagnosis, endoscopic assessment, because then it kind of guide you what you should do. So if it looks like high risk for submucosal invasive cancer, you don't have, I'm talking about in the colon. If you really unsure, you can do limited biopsy, but if otherwise you don't have to biopsy, you can place tattoo away from the lesion about 5 centimeters away, so that the tattoo doesn't spread to the lesion later on, and refer, right? But if during the examination, that's the features of deep invasive cancer, you do a lot of biopsy because you want to confirm, and you also tattoo. So what will make you decide what action to do during your procedure is what you think it is, your endoscopic diagnosis. So learn that, and when you see this lesion, if you look quite confident that this is benign, then you go ahead and tattoo, and again, not near the lesion, and make sure that you document clearly about the lesion, size, where it is, and a lot of image, good image on it, near close view, far view, NBI. That's actually very helpful when we get referral and we decide what to do with it. Because sometimes we see the picture, oh, this is cancer. We don't have to bring the patient just to tattoo it. We don't have to, right? So, and it helps planning. When I see the lesion, this area look like could be invasion there, could be submucosal invasion here. So we're gonna design ESD. Sometimes I always ask for colored pictures from the procedure before I schedule. If it look quite benign, then I just schedule EMR. So clearly document the lesion and take a lot of photographs. If you tattoo, make sure you say in your note where you tattoo from the lesion. You tattoo proximal, distal, and take picture to confirm the location. And so very hard is that if this is an endoscopically resectable lesion and you perform any intervention that creates scar on it, whether it's multiple biopsies, tattoo near the lesion, near or at the lesion, or some people even snare, saying that, you snare to get a big piece of biopsy, but that can lead to fibrosis, particularly the flat lesion. If it's like sessile lesion, bulky lesion, it usually doesn't cause fibrosis for that. But the flat lesion, once you biopsy, the scar will form at the base. So yeah, avoid this action. That would be very helpful and will make the procedure much easier for us.
Yes, yes. What is your advice if somebody's listening and they really want to start doing ESD? What would you suggest to them?
Yeah, if someone have, I want to learn ESD, it really need commitment to do it, because it's not something you go to the course couple of times, spend couple of months, and you can do. It's not like that. If you really committed to do, it takes several years to be able to do it. Even we have the fellows, our fellowship is 2 years. Toward the end of the second year, they like a little bit more comfortable to do the small lesion. But if you committed to do, then you have to spend, you have to think about, spend time, learn about how to, endoscopic assessment, learn about management of the disease that ESD will use it for. Otherwise, we will not know when we should apply this technique to. Then if you, that passed, you already know indication. First, go to the course. This is, for me, I think it's very important, because you have to have interaction with people who can do it. If at your institution doesn't have anyone perform, and you will not be able to learn from them, you need to go out. The course, there are several courses like ASGE, Boston Scientific also have the course that hands-on. The mainly is to the hands-on part, because you really learn how to move the scope. This is the new skills in learning how to control the scope that you don't learn by doing EMR, ERCP is different. So go to the course and watch a lot of live demonstrations. See how they move their hands, the technique, when they cut, where to cut first, how they avoid complications, and so on. Once you have enough hands-on experience, probably have to take some time when you start to think, I'm ready to do in the patient, get proctor. So I think if it's available, it's very helpful, because when you first start, a lot of unexpected things can happen. Yeah. So get proctor, I think it's safer. You can schedule several cases in a day, and 2 or 3 cases, and then have someone who experienced, who you maybe have trained with, to come and watch you, who can guide you. Because sometimes I ask the fellow, no, you have to go inside the flap, move the flap away to expose submucosa, and then they couldn't do it. So sometimes we have to help. I'm not sure that it's available everywhere, but get proctor would be helpful. You have to continue to learn. When you do, what happened is, when I start doing, I feel that I have difficulty here. Now I go back to watch the video. I record a video of my procedure, because sometimes I go back to look, why there was a bleeding? Why did I didn't see that blood vessels? There's a superficial muscle burn there. When did my knife touch that area? I have to go back and look at it, and then I learn from my own experience.
That's actually amazing. Do you still record every case that you do?
Yeah, if I don't forget, I do.
And do you still go back and review them, or only if something goes wrong so you can review what went wrong?
Yeah. Initially, I go back more frequent than I am now. I go back now when I feel that what happened at that time, that this another thing happened. So not frequent now. But I want to have, when things happen, when I give it to the fellow, and why there's a muscle burn here? When did that happen? We go back to look at the video. Oh, your knife was a little bit too deep. I look at the video with the fellow, and next time we have to be careful here.
I think that's an amazing idea. My husband was a college gymnast, and this is a common thing to do in all sports, but they would video their practices, and then they would go back and watch, and they could get so much better because they could see where they had errors. And so I've never heard of that technique with endoscopy, but it makes a lot of sense, actually.
The reason I do is that because when I was in Japan at National Cancer Center, they record all cases.
And then do they do the same thing, and then they review them?
I know they review them, but I don't know how often they do. That's why they record it.
Okay.
Yeah.
Very interesting. Well, this has been amazing. Thank you so much for coming on today.
Thank you for having me.
Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, EduCare. That's edukare.bostonscientific.com and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.